Good morning, everybody. Welcome to my next series of lectures on weaning. The step 10 is treat all the reversible causes identified. Provide good nutrition but avoid overfeeding. Have good glycemic control, that is 110 to 140 milligram %. Correct the metabolic factors, especially the metabolic alkalosis. Maintain the hemoglobin above 7 to 8 gram deciliter. Maintain the adequate cardiac output and tissue perfusion. Treat the arrhythmias. Treat the hypothyroidism and steroid deficiency or excess. Control the patient's underlying illness. Abolish the ventilator dysynchrony with appropriate inspiratory flow and trigger settings. Change of the mode of ventilation may help to improve the patient-ventilator interaction. Reverse the bronchospasm as much as possible and reduce the dynamic hyperinflation. Drain out the significant pleural effusions and ascites. Treat the intra-abdominal hypertension. Treat the pulmonary edema aggressively. Discontinue the use of steroids, aminoglycosides, cholesterol and statins if possible. Avoid the fluid overload in renal failure and cardiac failure. Do dialysis if indicated. Make the patient comfortable. Aggressive physiotherapy and mobilization. Reverse the oversedation. Treat the anxiety. Improve the patient communication and use the relaxation techniques and give low dose benzodiazepines. Diagnose and treat the narcotic or benzodiazepine withdrawals. Treat the delirium and depression. Ensuring nighttime sleep may be helpful. Step 11, that is plan the weaning process in difficult weaning. Number 1, select the mode of ventilation. The mode of ventilation should provide adequate respiratory support and prevent the diaphragmatic atrophy. Pressure support ventilation, it is most commonly used and has been shown to be better than SIMB for weaning. Continuous positive airway pressure CPAP, besides the usual benefits of improved oxygenation and improved ventricular function, it has the beneficial role in selected patients with hypoxic respiratory failure. Automatic tube compensation. It may be helpful in narrow endotracheal tubes to overcome tube resistance. Proportional assist ventilation. It has been suggested with CPAP and shown to improve the respiratory mechanics. adaptive support ventilation. It has been shown to be better than SIMV in post-cardiac surgery patients. Controlled mechanical ventilation, that is CMV. It has logical use in patients showing respiratory fatigue on spontaneous mode. So it is recommended to use this mode in cases of difficult weaning at night to give rest to the muscles. Flanked tracheostomy. Percutaneous tracheostomy has been shown to have fewer complications than surgical tracheostomy and to be more cost effective. Potential benefits of using tracheostomy in difficult to wean patients are as follows. Number 1, decreased work of breathing. Number 2, reduced requirement of sedation and improved patient comfort and cooperation. Then earlier reinstitution of oral feeding and less chances of accidental extubation. In spite of the above mentioned benefits, tracheostomy has not been consistently shown to decrease the mortality. It has resulted in a number of dependent survivals. It facilitates easier bedside management of such patients. Number 3, do aggressive physiotherapy and mobilization. Physiotherapy and mobilization are prerequisites for successful weaning. Early institution of physiotherapy in a protocol-driven approach and daily assessment to achieve the maximum mobility is now an integral part of ICU management. Number 4, that select proper place for weaning. Cost-effective care has been shown to be provided in respiratory intermediate care units and specialized regional weaning centers. It requires the team effort and expertise. Step 12, that is, choose a weaning protocol. Protocol-driven weaning has more chances of success, reduced costs, and probably reduced mortality. 2 basic weaning protocols are used for a prolonged weaning patient. Number 1, progressive reduction of ventilator support. Number 2, progressively longer periods of spontaneous breathing trials, SBTs. No significant difference in weaning success and mortality rate, duration of ventilatory assistance, or total hospital length of stay is reported between these 2 weaning techniques in the difficult to wean patients. A combination of both the protocols can be used. Step 13. Decide about home ventilation. Indication. An inability to be completely weaned from ventilator support include the NIV. A progression of disease etiology that requires increasing ventilator support. patients should have stable physiology and proper resources, personnel and motivation. Now we come to the end of my lecture series about weaning. Next time we will deal with other interesting topics. Thank you.